Hello everyone. This presentation will be on fat-soluble vitamins in pediatric practice. As we all know, the fat-soluble vitamins are vitamin A, vitamin D, vitamin E, and vitamin K. This presentation will confine about the physiology of each, as well as about the deficiency, as well as hypervitaminosis states of all these four. It is important to know all of these because on the left you can see a perfectly normal child, whereas on the right you can see extensive corneal scarring because of vitamin A deficiency. It is important to note that in malnutrition there is both an undernutrition as well as an overnutrition component. Vitamin A undernutrition was widely recognized and it is the most common preventable cause of blindness which is there. So it is important to know about these conditions, and at the same time only what the mind knows the eyes can see. The eyes cannot see what the mind does not know. So with that we'll just come to each of these vitamins under the principles of active compound, physiology, recommended daily allowance, deficiency state treatment, prevention, and hypervitaminosis as well. Unlike the water-soluble vitamins B and C, hypervitaminosis is a manifestation which is dreaded complication for all these four, so it is important in all these four vitamins. Coming to vitamin A, the deficiency of it is clinically seen in all these countries which are marked in red. So India is one place where there is a clinical deficiency to be noted. Vitamin A chemically is a derivative of retinoids and it helps in maintaining cellular integrity, immune competence, and growth. But the specific function to vitamin A is the vision. It helps in the visual pathway. Sources wise, it is there both from animal and plant. Animal source from most animal sources are good availability. Specifically in plants, it is seen in beta carotenes, in antioxidants. So carrot is a very good source of vitamin A. There's always that famous image of vitamin A with Bugs Bunny posters in the clinics where children are encouraged to eat carrots, keeping this in mind. The recommended allowance is 300 to 400 microgram per day in infants, 400 to 600 microgram per day for children, and 750 micrograms for adolescents. Deficiency wise, it is classified into subclinical, eyes, skin, and genitourinary system as well. But subclinical deficiency and deficiency in the eyes is commonly seen. It is important to note that certain conditions can aggravate a pre-existing vitamin A deficiency, namely measles, a worm infestation, or diarrhea. Measles is preventable by vaccination. Worm infestation can be treated by regular deworming, and diarrhea can be prevented by routine hygiene measures as well as symptomatic treatment to limit the complications. Like I mentioned, vitamin A deficiency is a preventable cause of blindness. This image shows certain eye changes in vitamin A. The first image shows bitered spots, which is seen in the initial stages of X1b. There is a WHO classification. I'll come to it in the next slide. The second image shows corneal scarring. As you can see, the cornea more or less is normal, but there is a segment of scarring which is noted. The third image, there is more or less corneal xerosis, but there is circumferential involvement at the limbus, a bit more. Pupillary involvement is also there. You can see the pupillary corneal margins is also involved. And this is more or less extensive scarring or complete xerosis, where the distinction between pupil and rest of the cornea is not seen. Like I mentioned, there is a WHO classification for vitamin A deficiency. XN is nothing but night blindness. X1A is conjunctival xerosis. X1b is bitered spots, as you saw in the first image. X2 is corneal xerosis. X3 is a corneal ulcer less than 1/3. X3b is a corneal ulcer more than 1/3 of the cornea. Fundal changes and corneal scarring comprise of XF and XS. I'll show the ulcer once more. You can see this as a corneal ulcer itself. The ulceration is noted. Coming back to the main slides, If you consider the treatment for vitamin A deficiency, locally based on ophthalmological consultation, you can give an eye patch or a mydriatic for symptomatic treatment. But the specific treatment is only by supplementing vitamin A. The dosage at less than 6 months is 50,000 international units. 6 months to 1 year is 1 lakh international units stat dose, and more than 1 year is 2 lakh international units stat dose. The capsules are available as 25,000 international units per capsule is the availability in the market. So a child more than 1 year requires 8. If you go to the prevention side, as of right now in Anganwadis, 1 spoon of vitamin A, which corresponds to 1 lakh international units, is given in Anganwadis as well as in the public sector, along with the measles vaccination at 9 months. So that helps in the prevention overall. It is not a part of the routine IAP schedule or as a part of the UIP schedule, but it is commonly practiced in the government setup. Breastfeeding as well as dietary advice is an important component for preventing vitamin A deficiency. If you see hypervitaminosis, there was a case report where as a part of the vitamin A strategy campaign of the UNICEF, 1,000 children fell sick on the same day, reporting 15 deaths with bulging of anterior fontanelles. So hypervitaminosis is a dreaded complication which is attributed in this case specifically to the vitamin A campaign. If you consider the teratogenicity of vitamin A, it is known to be a teratogen. Antenatally for the mothers, it's best to be avoided. And it is also given for the treatment of acne vulgaris because of the tretinoin usage in this condition. In obstetric practice, it is advised not to conceive for 100 days after using a tretinoin therapy. To summarize about vitamin A in general, it is easily treatable and easily preventable as well. And it is the most common, simple, treatable cause of preventive blindness. Generally, it is a subclinical deficiency, but it is also a common deficiency which can be treated. Moving on to vitamin D, it is important in maintaining the bone health as well as calcium homeostasis, and it is proven to play an important role in overall health and preventing diseases. The deficiency of vitamin D can be considered as a pandemic based on recent data, and there is a high prevalence rate worldwide, irrespective of age groups and across different countries as a whole. If we consider the metabolism, D3 is absorbed through skin as well as through the diet, and once absorbed within the liver forms 25-hydroxy D3. Further, in the kidney, hydroxylation occurs again, which results in 125-hydroxylation to 125-hydroxy D3, which in the presence of calcium and phosphorus acts on parathyroid hormone, which results in the formation of the active form. It's important to note that ergocalciferol is obtained from plant source, and D3, that is cholecalciferol, is produced only by the skin in the presence of UV radiation, specifically only because of the UVB and not because of the UVA. That is important to keep in mind. If you consider vitamin D receptors in non-bone tissues, it is seen in the heart, intestine, liver, kidney, lungs, brain, skin, pancreas, and other immune cells. It is interesting to note that vitamin D deficiency is an important cause of dilated cardiomyopathy. So that is an important point which I would like to highlight here. It is somewhat of a rare condition, but it is something which we should keep in mind. Recent literature also suggests that there is a autocrine and a paracrine role for vitamin D because of its additional action as an endocrine hormone, and there are other autocrine effects which is independent of regulation by the serum calcium as well as phosphorus and parathyroid hormone levels. Based on this observation, it is noted that vitamin D also has a role in regulating its other non-skeletal related functions. But if you do consider the paradox where we see that in spite of abundant sunshine, there is a decrease in vitamin D levels in certain individuals, we should also consider atmospheric pollution, skin pigmentation, the use of sunscreens, genetic factors, and even to somewhat of an extent, the amount of skin which is exposed in these people. If you go into the little bit of physics aspect of it, UVB radiations has a shorter wavelength and does tend to scatter earlier or later in the day, which means that the vitamin D synthesis is maximum between 10 a.m. to 3 p.m. So if you consider a pediatric population, that's when kids are in school, so they are not exposed as much. And if you also consider that these individuals have a full body clothing as opposed to somewhat less, even then the surface area which is exposed also plays a role with regard to the amount of vitamin D which is synthesized. It's interesting to note that melanin in our epidermis acts as a natural sunscreen, and that also helps in reducing the risk of skin cancer which is induced by UV radiations, and also reduces cutaneous vitamin D synthesis. So if you compare two individuals, one who is an Indian Asian and a comparatively fairer person from a Western country, we require 3 times the amount of sun exposure here in India than a Westerner for an equal amount of vitamin D. And it's also interesting to note that sunscreens block UVB radiations more than UVA. So as a result of which, use of sunscreen itself will cut down on our vitamin D exposure. If you consider sources wise, vegetarian sources are limited. Non-vegetarian sources are there in the form of fatty fish, organ meat, egg yolks. Vegetarian source includes purely milk products, but sunlight is the best source of vitamin D. If you see the recommended daily allowance, infants require 400 international units, children 1 to 6 years require 600, and subsequently 1000 international units per day is required for a normal child just to maintain their vitamin D status without considering any deficiency. A deficiency of vitamin D manifests as rickets, and it is important to understand that this results in skeletal abnormalities and skeletal deformities. So it is important to identify early, treat early, and if possible, best is prevention rather than treatment. Serum 25-hydroxy vitamin D level is the best biomarker available for the diagnosis of vitamin D deficiency, and this is a better marker than 125-hydroxy vitamin D. So I would like to stress upon that whatever assays we do is for 25-hydroxy vitamin D. If you see as far as the status in relation to the levels, deficiency is considered to be less than 15, whereas in some places they do consider even less than 20 to be deficient. But there is absolutely no doubt less than 15 is deficiency. Some institutions consider 20 as per their protocols. 15 to 20 is considered as an insufficiency, 20 to 100 is considered as a normal range, anything more than 100 is an excess, and more than 150 is considered in the range for intoxication. It's important to note we measure vitamin D in various units. 400 international units corresponds to 10 microgram, which corresponds to 26 nanomole. I repeat myself, 400 international units corresponds to 10 microgram, which comprises of 26 nanomoles. The deficiency of vitamin D results in rickets. It's unusually seen in less than 3 months, but congenital rickets is seen. It's generally seen for more than 6 months to 3 years of age. We can subclassify it into nutritional, vitamin D resistant, vitamin D sensitive rickets, and non-nutritional because of renal involvement, renal rickets, or liver involvement. If there is no skeletal growth, there is no manifestation of rickets. I would like to highlight upon this point very specifically. And vitamin D deficiency rickets is a disease of a growing bone. If you consider clinical features of it, craniotabes will be present with a wide anterior fontanelle. Wide anterior fontanelle is often the only sign what is seen, and it should be identified quite early, as opposed to a normal anterior fontanelle associated with frontal and parietal bossing and caput quadratum. In this trial, you can see craniotabes as well as bossing of the parietal region. If you see the other features from head to toe, lamellar cataract can be seen along with poor enamel formation in the oval cavity. Wide wrists will be seen in the upper limbs, and that used to be pathognomic in the older days where there was no availability of vitamin D assay. Wide wrist itself is suggestive of rickets. If you see the chest features, a rachitic rosary will be present, as you can see in this child here, along with pectus carinatum and Harrison sulcus. Abdominal features include a pot belly with spinal features of kyphosis and scoliosis. Bow leg is characteristically seen in rickets, and that is pathognomic along with double malleoli. Apart from this, it can also present a short stature, and as a result of all of this can also have a motor developmental delay, but other spheres of development will remain normal. If you just consider the biochemical changes per se, the presence of vitamin D will help in decreased calcium absorption from the gut, which will result in decreased serum calcium if there is a deficiency. As a result of which, there will be an increased parathyroid hormone, which also means that calcium desorption from the bone will be less. There will also be increased calcium excretion from the kidneys, and reabsorption from the kidneys will be more. As a result of which, there will be increased osteoblastic activity, resulting in alkaline phosphatase being increased. That is a mechanism for increase of alkaline phosphatase. If you consider the radiological features which are seen in rickets, cupping, fraying, and splaying are three characteristic words which are used to describe this X-ray. All three features are characteristically seen. Cupping of the wrist joints are seen along with fraying and splaying, all of which result in a wide appearance at the wrist joint. This X-ray of the lower limb shows a characteristic bow leg. The bow-like appearance is characteristically seen along with even a bending of the femur anteriorly. I will mark that once more. There is a slight bending of the angle of the shaft of femur as well, along with a generalized bow appearance. Diagnosis of rickets is made clinically, biochemically, as well as radiologically. If you come to the treatment of proven deficiency, 6 lakh international units of vitamin D is given for those who are proven to be deficient, along with calcium and phosphorus supplements. X-rays are advised to be repeated after 2 weeks until the white line is visible. If not visible on the X-ray, it's suggested to repeat 6 lakh international units and labeled as resistant rickets at that. If you go for pre-rachitic deficiency, based on the serum levels of 25-hydroxy vitamin D, high dose therapy is given either as pulse or regular therapy for either 3 months or for 8 weeks, depending on the age and depending on the levels. If the levels are less than 5 at 3 months of age, 8,000 international units low dose is given, 50,000 units 8,000 units is given every day as low dose therapy, and if you consider a high dose therapy, it's 50,000 units per week for 4 weeks. Above 3 months of age, if it is 5 to 15 nanogram per ml, 4,000 units is given as low dose and 50,000 is given every fortnight. And 16 to 30 nanogram per ml of 25-hydroxy vitamin D will result in 2,000 international units per day as low dose, or 50,000 units per month in addition to that. Prevention-wise, dietary recommendations are there, along with supplements, which forms a mainstay for vitamin D deficiency and exposure to sunlight. I would like to mention that all newborns are advised to have 400 international units of vitamin D for 1 year as per the IAP recommendation latest, and 800 international units is recommended if the mother is proven to be vitamin D deficient. 600 international units is recommended for preterm. Apart from this, calcium is now slowly trickling in with a requirement of calcium to be supplemented along with vitamin D. So the new recommendation, slide changed. The new recommendation is calcium plus vitamin D, because giving vitamin D alone is not sufficient. It's advised to give calcium along with it. Features of hypervitaminosis of vitamin D include anorexia, hypotonia, irritability. Failure to thrive is a bit late complication of it, and by which time classical features of rickets might be seen, but hypervitaminosis can also present as failure to thrive. So you can see this in both spectrums. But hypervitaminosis characteristically seen hypotonia of sudden onset, irritability, anorexia, failure to thrive in a child which was previously growing normally well, along with calciuria and metastatic calcification are important to be noted. To summarize about vitamin D, it is not just an endocrine, but it is also having an autocrine and a paracrine function. Deficiency is seen in rickets, and rickets is purely a disease of a growing bone. That is important to highlight. Causes might be nutritional or non-nutritional, and the diagnosis of rickets is both clinical, biochemical, as well as a radiological diagnosis, and it can be easily treated by supplements. Latest guidelines do recommend adequate supplementation to all newborns, which will subsequently prevent rickets in subsequent life. Coming to vitamin E, the active component of which is tocopherol. It acts as an antioxidant as well as it has an anti-neoplastic effect. It increases the amount of HDL cholesterol. So it is one of the only factors, non-cardiac, which increases HDL cholesterol and is present in good sources from nuts as well as from polyunsaturated vegetable oils. If you consider preterm and infants separately, the preterms require 15 to 20 international units per day, and infants require 3 mg of alpha tocopherol as the daily requirement. Deficiency of vitamin E is generally seen only in low birth weight babies. It's also seen in anemia, thrombocytopenias, and it decreases the incidence of retinopathy of prematurity as well. And clinically, it will manifest as a loss of deep tendon reflexes with ataxia. Rarely, it will show other symptoms like muscle weakness, ptosis, and dysarthria. And if you do consider prevention, of which is best maintained by dietary sources. Coming to vitamin K, vitamin K is a clotting factor dependent vitamin. Basically, 4 clotting factors, that is 2, 7, 9, and 11, are all dependent on vitamin K. The best source of vitamin K is green leafy vegetable as well as the gut flora. That is missed out in the slide. I would like to add that. Gut flora is also a good source of vitamin K. The deficiency of vitamin K will result in nothing but coagulopathy. It is also seen in various conditions like hepatitis. So any child who is admitted for hepatitis requiring treatment, it is good to give a stat dose of vitamin K along with that. In newborn, vitamin K manifests as hemorrhagic disease of the newborn, which is preventable. Basically because newborn are deficient in vitamin K, as a result of which vitamin K is not present, and vitamin K 1 mg is routinely given for all newborns at birth itself. Giving this 1 milligram of vitamin K at birth has gone a long way in preventing hemorrhagic disease of newborn, and treatment can be given by vitamin K supplements if given otherwise. To summarize, the fat-soluble vitamins are vitamin A, D, E, and K. Vitamin A deficiency will result in blindness as a result of, specifically night blindness, as a result of relative vitamin A deficiency, which can be prevented by vitamin A supplements routinely at 9 months of age as introduced by the government. Vitamin D deficiency is seen in rickets. Rickets is a disease of the growing bone, and vitamin D deficiency is preventable by giving vitamin D supplements during the breastfeeding duration. One point which I did not mention during the presentation, breast milk is deficient in vitamin D, as a result of which supplementation is a must. New recommendation does suggest giving calcium along with vitamin D to help in facilitating the bone growth. Vitamin E deficiency is characteristically seen in anemia. As a whole, it is rare and can be supplemented. Supplementation by diet itself is more than sufficient in most cases. Vitamin K deficiency characteristically presents as coagulopathy and is prevented by giving 1 milligram of vitamin K stat dose at birth itself. The sources of all these fat-soluble vitamins collectively is cheap and easily available. Early detection goes a long way in preventing mortality and morbidity as a result of the deficiency of these vitamins. I thank all of you for paying attention to this presentation. I thank you all for tuning in. This presentation is targeted at medical students and does not replace the advice of a medical practitioner from a patient point of view. I also would like to acknowledge the Indian Academy of Pediatricians who made these slides, and thank them for keeping the access of it open as a learning tool for everyone. Thank you, one and all.